Welcome back to What the Study Says. GLP-1 drugs are being hailed as the greatest medical breakthrough of the century for weight loss and heart health. But at the exact same time, governments in the UK and Brazil are issuing alarming warnings about fatal pancreatic diseases linked to these very same drugs. So are they miracle molecules or ticking time bombs?
I mean, it is just the ultimate medical whiplash for the public right now. You have patients completely desperate to get their hands on these medications.
Absolutely.
And then in the very next breath, they're terrified of this potential organ failure they just read about on their newsfeed.
Which is exactly why we are doing this. As professional doctors, we both know how easy it is to get swept up in those sensationalist headlines.
Yeah, the media spin is intense.
Right. So we decided to independently bypass all that, ignore the talking heads, and dig directly into the raw medical data. We custom-tailored this deep dive specifically for you, the listener, to help you understand exactly what is happening inside your biology and, well, to the public at large.
Because the underlying physiology here is incredibly complex. I mean, to figure out if these warnings are justified, we have to look at the actual clinical evidence. We need the pharmacological mechanisms, not just, these alarming anecdotes.
Yeah, today our mission is to unpack a massive stack of freshly published research. We're looking at the groundbreaking SURMOUNT-1 and SELECT clinical trials.
Which are huge.
Massive. Plus a huge 2025 meta-analysis of 62 trials by Wen and colleagues, a U.S. database study of over 160,000 patients by IUB, and of course, those recent government health warnings.
It's a mountain of data, for sure.
Yeah.
But when we synthesize it, it paints a very clear, as honestly, surprisingly different picture from what you're seeing on the evening news.
Definitely. But before we can even begin to understand the government panic, we first have to understand why these drugs have exploded into the public bloodstream in the first place. I mean, we are seeing adoption rates that rival statins back in the 1990s.
Well, easily. And to grasp the scale of the benefits, we have to look at the SURMOUNT-1 trial. This was a massive study published in the New England Journal of Medicine looking at the drug tirzepatide.
Right.
Now, tirzepatide is unique because it doesn't just target one receptor. It targets two distinct hormonal pathways in the body, so both GIP and GLP-1.
Wait, hitting two pathways instead of one, doesn't that just mean double the side effects? I mean, clinically speaking, the more we interfere with the endocrine system, the more collateral damage we usually see.
Yeah, that is a highly logical concern. But the pharmacology here is actually synergistic. It's not just additive. So native GLP-1 is a hormone produced in your gut that delays gastric emptying.
Right. It keeps food in your stomach longer.
Exactly. And it signals satiety in your brain's hypothalamus. It essentially tells you that you are full.
Okay. And what about GIP?
Well, GIP strongly enhances insulin secretion, but it also fundamentally improves how your body deposits fat. It shifts it away from those dangerous visceral organs and puts it into safer subcutaneous storage.
Wow. So by mimicking both, tirzepatide effectively rewires the body's entire energy regulation system.
Exactly.
And I mean, the numbers really reflect that rewiring. Among the 2,539 participants in the SURMOUNT-1 trial, the results over 72 weeks were staggering.
Truly unprecedented.
Yeah, patients taking the 10 milligram dose saw an average body weight reduction of 19.5%. And those on the 15 milligram dose, they lost an average of 20.9% of their body weight.
Just think about that. Losing a fifth of your body weight pharmacologically is, well, it's never been done. Historically, the only way we achieved those kinds of numbers in medicine was through invasive bariatric surgery.
Which comes with its own host of severe surgical risks, right?
Exactly.
But the benefits don't stop at the scale, which brings us to the SELECT trial, led by Dr. Linkoff and his team. This is the trial that really shifted the global narrative from vanity weight loss drug to actual life-saving medication.
Yeah, this was the game changer.
They looked at 17,604 overweight or obese patients. And the critical variable here is that none of these patients had diabetes.
Right, no diabetes.
But they did have pre-existing cardiovascular disease.
And by isolating the study population this way, the researchers proved we're looking purely at the cardiovascular impact of the drug on obesity. We're stripping away the known cardiovascular benefits of simply lowering high blood sugar in a diabetic patient.
Exactly. So they gave these patients a weekly 2.4 milligram dose of semaglutide, and the result was a massive 20% reduction in the risk of major adverse cardiovascular events.
20%.
Yeah, we are talking about preventing death from cardiovascular causes, non-fatal heart attacks, and non-fatal strokes. In cardiology, a 20% risk reduction from a single intervention is monumental.
It really is. But the SELECT trial also revealed something deeply fascinating about the mechanism behind that protection, which was a nearly 38% drop in high-sensitivity C-reactive protein, or hsCRP.
Okay, let's unpack this. CRP is a biomarker for systemic inflammation. It's not just a passive indicator, you know. It tells us that the endothelial lining, so the inner wall of your blood vessels, is highly reactive and inflamed.
Exactly, it's a red flag.
Right. When CRP is high, your arteries are essentially structurally angry, making plaque highly unstable and prone to rupturing. And that is what causes a heart attack. So, if GLP-1s are dropping CRP by 38%, it's like we are injecting a systemic coolant directly into the body's vascular reactor core.
That's a great way to put it.
We aren't just siphoning off the excess fuel, the adipose fat. We are chemically lowering the temperature of the entire vascular system to prevent a catastrophic meltdown. It's like a systemic software update. We aren't just deleting bad files, we're optimizing the whole operating system to prevent a hardware crash.
And that is the paradigm shift we're witnessing. We are no longer just treating the outward symptoms of obesity. We're chemically treating the root cause of systemic cardiovascular decline. We're cooling off those inflammatory cascades while simultaneously unloading the mechanical stress on the heart by reducing the body's physical mass.
But, you know, every powerful software update has a potential bug. With millions of these prescriptions being written globally, the public is suddenly terrified by headlines of organ failure, specifically the pancreas.
Yeah, the transition from miracle to menace in the press happened almost overnight.
So let's look at the data driving that fear. A recent report in Nature highlighted some highly publicized moves by regulatory agencies. In January of 2025, the UK issued a severe warning after recording 19 deaths from acute pancreatitis linked to GLP-1 since 2007.
19 deaths over that period.
Right. And to put that in perspective, about 1.6 million adults were using these drugs recently in Britain alone. Then, just 10 days later, Brazil issued a similar warning, noting 6 deaths since 2020.
This raises an important question, though. How do we interpret those raw numbers in a clinical context? Because yes, 19 deaths is an absolute tragedy. But in population health, we have to look at the concept of notoriety bias and, well, baseline pathophysiological risk.
Wait, are you saying doctors are just diagnosing it more because the drug is famous?
Partially, yeah. When a drug becomes infamous in the media, physicians become hypervigilant. Every single abdominal pain in a GLP-1 patient gets charted and reported to regulatory databases because it's top of mind. But the larger issue is the baseline risk itself.
Okay, walk me through that.
Obesity itself and the rapid lipid mobilization that these drugs cause, those are already massive physiological risk factors for developing gallstones.
Right, let's look at the plumbing of the human body. When you lose weight rapidly, your liver is actively processing all that mobilized fat. In doing so, it dumps excess cholesterol into your bile.
Exactly.
And that bile sits in your gallbladder, becomes completely supersaturated, and crystallizes into stones.
And anatomically speaking, the gallbladder and the pancreas share a common drainage tube, the ampulla of water that empties into the intestines.
Right, they share the same exit.
Yeah, so if one of those cholesterol stones travels down and blocks that common tube, the highly corrosive digestive enzymes produced by the pancreas, like trypsin, get completely backed up. They activate prematurely and essentially start digesting the pancreas itself.
Which is acute pancreatitis.
Exactly. It's incredibly painful, causes systemic shock, and as we've seen, it can be fatal.
I have to offer some firm pushback against these government warnings, though. Are these government databases just collecting statistical noise? I mean, these are self-reported pharmacovigilance databases. Anyone can report an adverse event.
Very true.
So how do we, as scientists, know if the GLP-1 molecule itself actually inflamed the pancreas directly, or if the patient's underlying metabolic disease or the gallstones formed from rapid fat loss was the true culprit?
Well, that is the exact blind spot of these warning databases. They collect temporal events, right? Like patient took drug, patient got sick.
Yeah.
But they absolutely cannot prove causality.
Right. Correlation isn't causation.
Exactly. To figure out if the drug is the true culprit, you have to strip away the confounding variables. You need cold, hard statistics and stringently controlled environments.
Which brings us to the data reality. To answer that exact question, we have to isolate the pancreas.
Right, and we have a brilliant 2025 meta-analysis by Wen and colleagues that attempts exactly this. They pooled data from 62 randomized controlled trials covering 66,232 patients.
So I'm looking at this WEN meta-analysis of over 66,000 patients, and honestly, initially it looks like bad news. When they looked at the raw data, they hit a risk ratio of 1.44 for pancreatitis in patients taking GLP-1s.
Yep.
That's a 44% higher risk compared to the control group. To me, looking at that raw number, that screams the UK and Brazil warnings were completely justified.
Well, it looks that way until you look at their methodology. The researchers then did something crucial. They stratified the data based on background medications.
Oh, interesting.
You have to remember, many patients in these early trials were diabetic. They were taking other glucose-lowering medications alongside the GLP-1s, like DPP-4 inhibitors.
And those have their own controversial pancreatic risk profiles, right?
Exactly. When the researchers statistically adjusted for those background medications, the statistical significance for pancreatitis completely vanished.
Wow. So the risk was essentially a ghost in the machine. It was just tangled up with the other drugs the patients were already taking.
Precisely. The GLP-1 wasn't the independent trigger. Furthermore, when they looked at the ultimate long-term fear pancreatic cancer, they found no overall significant association with GLP-1 use whatsoever.
That's a huge relief. But the WEN meta-analysis is still just looking at clinical trials. And clinical trials are notoriously strict. They exclude the messy, non-compliant, real-world patients we see in our clinics every day. We need to know what happens when this drug is in the wild.
Which is why we turn to real-world data, analyzed with surgical precision. And that brings us to what I consider the ultimate mic drop study, published in 2025 by Iob and colleagues.
Ah, yes.
They utilized the TriNetX US database, analyzing over 160,000 patients.
And to clean up the noise of real-world data, they used a rigorous statistical technique called propensity score matching.
Propensity score matching is incredibly powerful. Imagine trying to find identical twins in a massive crowd of hundreds of thousands of people.
Right.
They took 81,872 patients actively taking GLP-1s and mathematically matched them with 81,872 patients who were not taking the drugs. They matched them on age, gender, BMI, and crucially, they ensured all these patients were comorbidity-free.
Which is wild because finding a comorbidity-free obese patient is incredibly difficult.
It really is.
It means they filtered out anyone with existing heart disease, chronic kidney disease, a prior history of gallstones, or a history of alcohol abuse, all things that independently cause pancreatitis. They leveled the playing field entirely to isolate the variable down to just the drug itself.
And the stunning result of that isolation, there was absolutely no increased risk of pancreatitis at 6 months, 1 year, or 3 years.
Zero statistical difference. That is amazing.
Actually, it gets more interesting. When they looked at the lifetime risk of developing pancreatitis, it was lower in the GLP-1 group.
Wait, lower?
Yes. The risk was 0.3% for GLP-1 users, compared to 0.4% for the mathematically matched non-users. If we connect this to the bigger picture, the initial public panic about the UK and Brazil warnings is completely understandable human behavior. I mean, 19 deaths is scary.
Of course it is.
But when you zoom out, strip away the background noise, and look at the controlled data, the direct pancreatic risk from the molecule is incredibly rare. It's almost non-existent in healthy populations.
Yeah.
Meanwhile, the cardiovascular benefits are universally life-saving.
So what does this all mean? To me, it seems like the benefits of the systemic weight loss, the reduction in visceral fat, and that massive drop in inflammatory markers we talked about are literally outcompeting the drug's potential side effects.
Exactly.
By fixing the underlying metabolic dysfunction, you're lowering the patient's overall baseline risk for a whole host of diseases, effectively making the drug structurally protective for the pancreas in the long run.
The irony is profound, isn't it? The very drug people fear might destroy their pancreas is, statistically speaking, likely protecting them from a pancreatic event by healing their overall metabolic state and reducing systemic inflammation.
So GLP-1s prove we can systemically reverse metabolic decline with a single weekly dose. But, metabolism is just the fuel system. What happens when the physical architecture of the body, like the bones, the muscle reserves, is already crumbling?
Yeah, GLP-1s can't fix that.
Right. This leads us to the cutting edge of physical endurance, requiring a completely different cellular intervention.
We're talking about sarcopenia and clinical frailty. There was a fascinating study recently highlighted in Nature by Ruse and his team looking at this exact phenomenon.
Frailty is a condition that really doesn't get enough attention, but it is devastating.
It affects up to a quarter of people over the age of 50. And it's not just feeling tired, it's a measurable loss of physiological reserve.
Like losing your grip strength.
Exactly. Your walking speed plummets, your grip strength disappears, and suddenly a simple respiratory infection or a minor fall can become a fatal event because your body simply lacks the cellular energy to repair the damage.
And traditionally, modern medicine has no real answer for frailty. We tell patients to try and walk more. We prescribe physical therapy, maybe try to optimize their vitamin D levels. It's essentially putting a Band-Aid on a sinking ship.
It really is.
But the Ruiz study took a radical approach. They used a single dose of mesenchymal stem cells derived from bone marrow.
Mesenchymal stem cells, or MSCs, are incredibly unique. Yes, they can differentiate into various tissue types like bone, cartilage, and muscle. But their real power is their secretome.
What do you mean by that?
They act as massive biochemical factories. They just pump out anti-inflammatory signaling molecules and growth factors.
Okay. So they gave these stem cells to frail patients between the ages of 70 and 85. Now, typically, if you introduce foreign donor-derived cells into a human body, the host's immune system recognizes them as invaders and attacks.
Right, the rejection response.
Yeah. You usually have to put the patient on heavy, dangerous immunosuppressant drugs, which you obviously cannot do to an 85-year-old who is already clinically frail.
But these specific mesenchymal stem cells naturally lack the surface proteins, specifically MHC class II molecules that trigger those aggressive T-cell immune attacks.
Oh, wow.
They essentially fly completely under the radar of the host's immune system. No immunosuppressants are needed.
Here's where it gets really interesting. We need to rethink how these cells work. Instead of thinking of stem cells as just inert building blocks replacing dead tissue, think of them as general contractors arriving at a massive disaster site.
Oh, I like that analogy.
Right. They don't just become the new drywall. They release signaling cytokines that tell the body's native, localized immune cells to stop demolishing the inflamed area and actively start rebuilding the tissue matrix. It's like installing a brand new battery in an old smartphone.
And the clinical results of that rebuilding process were staggering. 9 months after receiving just a single dose, the patients who received the highest amount of stem cells could walk an average of 60 meters further in a standard 6-minute walk test compared to their baseline.
60 meters might not sound like, you're suddenly running a marathon. But in geriatrics, for an 85-year-old with clinical frailty, 60 meters is the difference between safely crossing a busy intersection before the light changes or being entirely housebound.
Absolutely.
It is the difference between needing full-time care and maintaining your independence.
What we are witnessing across both of these fields, so metabolic endocrinology with GLP-1s and regenerative cellular medicine with stem cells, is a fundamental shift in medical philosophy.
Yeah.
We are moving away from merely managing the symptoms of decline to actively intervening and rebuilding physiological resilience at the cellular level.
It is a profoundly optimistic time to be looking at medical data. So let's summarize this deep dive for you. The pancreatitis panic surrounding GLP-1s that you see dominating your social media feeds
is mostly noise.
Right. When you actually dig into the peer-reviewed numbers, it is largely statistical noise compounded by pre-existing conditions, rapid gallstone formation, and background medications.
The most rigorous data we have, especially from that propensity-matched U.S. database isolating those comorbidity-free patients, shows that these medications are overwhelmingly safe.
Safe and effective.
Exactly. They do not increase your direct risk of pancreatitis, and they offer historic, truly unprecedented cardiovascular protection by structurally cooling vascular inflammation.
And as we look to the horizon with stem cell therapy showing real promise in rebuilding physical endurance and reversing clinical frailty in the elderly, we want to leave you with a final provocative thought.
Yeah, think about this. If these dual therapies, GLP-1s optimizing our internal metabolic engines and stem cells rebuilding our physical architecture, can effectively buy us an extra decade or two of prime independent physical health.
How does that completely reshape our socioeconomic structure? If aging becomes a highly treatable medical condition rather than an inevitable decline, do we push the retirement age to 85?
It's a crazy thought.
And more troublingly, are we rapidly approaching a biological class divide between those who can afford these advanced cellular upgrades and those who are left to age naturally? It's something we are all going to have to reckon with very soon. If you want to keep cutting through the noise with us, make sure to subscribe and share what the study says. Let us know your thoughts, and we will catch you on the next deep dive.